We're going to let everybody populate, and it should be just a few moments here. And let's get this over here. And let's put this into present mode. And close you. Hello, everybody. We're going to start here in just a few moments. I have members of the HCMA team here to answer any logistical questions that you might have. So let me just take a quick opportunity to introduce Stacy Titus, our Center of Excellence Coordinator, who is, say hi, Stacy.
Good evening, everybody.
And Julie Russo, our Volunteer Coordinator, is here with us this evening as well. Julie.
Hi, everybody.
So when we go into presentation mode, Julie and Stacy will be behind the scenes. If you have any questions, you can use the chat box to communicate with them. In the event that you have any questions for our panelists, please use the Q&A box and we will moderate the questions as we go through. I'm going to do a quick screen share here. We are still waiting for a couple members of our faculty who are let us know that they were going to get here a little bit late. As we're kind of working amongst in our own community here, we're going to be a little casual this evening. So please don't hesitate to put up questions throughout the night to ask questions. So this is part of our HCMA Big Hearted Warrior Tour. This is a special edition, cardiac amyloidosis and HCM. And we were interested in this topic for a few reasons, and it was quite timely to bring it to everybody in this format, as there are a lot more amyloidosis patients hiding within HCM programs, and we want to make sure that every big heart gets the right care. And we thought we would take this opportunity to partner with Pfizer when we saw a grant opportunity pop up for education on amyloid. They like the concept. Once we're done with this program, we are also going to be offering an international program that we're putting together right now, probably for deployment in April. And that will be a CME course. This is just more of an internal group. So here we go. Our agenda tonight was supposed to have Mary O'Donnell. Thank you. From the Amyloidosis Foundation join us. She's been detained, so if she pops in later, we'll have her give a little bit of an introduction on their organization if you're unfamiliar with them. And then we're going to go through 3 talks today. We're going to be kind of quick on this, so we know you're all busy and there's a lot going on in the world right now. So we're going to hear from Mark Zucker from Morristown, New Jersey on the diagnostic challenges between HCM and ATTR. We're going to hear from Ethan Rowan on the prevalence of amyloid in a large HCM cohort. And then we're going to look at the therapeutic options for amyloidosis with Matt Moyer, who did let us know he was going to pop in a little bit late for another commitment. I did want to take just a moment of time to go over a couple HCMA items. Number 1, please mark your calendars. February 22nd is HCM Awareness Day. And we're asking each one of our Center of Excellence partners to put together a 5-minute what's going on in our center video. And Stacy will be emailing you information on this. Additionally, we're asking that everybody have a team meeting midday Eastern time, or maybe a breakfast meeting for those of you who are on the West Coast, and bring your teams together. We will play your video during HCM Awareness Day during our legislative briefing to bring everybody up to date on the status of the Healthy Cardiac Monitoring Act, which is legislation we are moving to identify children in their well child exams who have heart health histories that might need referrals to cardiology. You can see information on the act on our website, and we're looking for state level legislation, and we're going to have a legislative briefing around 11:30 a.m. Eastern on the 22nd, followed by what's going on in the HCM world from each of the centers. So a 5-minute video, screens on in a Zoom room to show your team. I even made t-shirts, and those t-shirts took a change because if you have not heard yet, there's a major motion picture with a guy named Tom Hanks. You might have heard of him. It's called A Man Called Otto, and Otto has hypertrophic cardiomyopathy. And the very interesting thing about the movie is the way HCM is depicted. It's beautifully done and it's very real. It's a little bit of a dark, he's a grouchy guy. It's a dark movie. There's some dark humor in here, but it is a very real depiction of life with HCM from a patient's perspective. So we changed our t-shirts to not everybody with HCM is grumpy like Otto. And we're going to kind of lean into that messaging because it's a great opportunity. I have been in communication with people behind the scenes including people from Sony Pictures. So fingers crossed that we get involved with them at a deeper level. I can't say more at this time. So stay tuned for that. Oh, this is my slide on, can Tom Hanks, like, what can he do to help us raise awareness about HCM? And that's all I really have on my slides. I'm not going to really get into that. Just wanted to introduce everybody, make sure y'all know what's going on out in the world. If your marketing teams did not participate in the HCMA marketing meeting last Thursday, they're going to be getting an email and a toolkit. And I encourage them to get involved with us before Heart Month starts. There's a lot going on and a lot we can do to highlight your programs. So I am now going to hand over the microphone and the screen to Mark Zucker. Mark and I have known each other a really long time in many different ways. And I know that Mark is very astute at that differential diagnosis between HCM and amyloidosis. And without further ado, Mark, you want to do your screen share and we'll all go cameras off, mics off while you're presenting.
Astute at amyloidosis, but not astute at screen share. Hold on. Hold on.
Technology.
Okay, share. Did that work?
Almost. Yeah, there we go. We're good to go.
So I can't see what I'm sharing then, right?
You can, you're not in present mode, so go off into present mode, click, and you should be able to see that your own screen.
Yes,
Yep.
I see my own screen. So you
Okay.
see the same thing?
Yep, see it. We're good.
Good evening, everybody. I was tasked with actually speaking tonight about differentiating cardiac amyloidosis from hypertrophic cardiomyopathy. I don't actually know if this is a CME talk or not, but I have no relevant disclosures for that purpose. I thought I would begin probably by describing both syndromes. Cardiac amyloidosis is defined by deposits of extracellular, what I call rogue protein, leading to biventricular wall thickening, impaired relaxation, loss of elasticity, and increased risk of death, sometimes due to a genetic mutation. Hypertrophic cardiomyopathy is defined by the presence of LV wall thickening, with or without RV involvement, impaired relaxation, increased risk of sudden death, often due to a genetic mutation. Even on this first slide, you can see why there's some overlap between these two syndromes. Fortunately, on the biopsy, you can make the diagnosis very easily. On the left is cardiac amyloid with the amorphous pink deposits, which are the amyloid deposits themselves. If this was a polarizing microscope, they would look apple green birefringent. On the right, you see the hypertrophic cardiomyopathy with fiber disarray. And grossly, both hearts, if you were just to give it to a medical student or a resident and say, what's what, they would actually probably phenotypically look very similar to one another with thickened ventricles. It's not a shock, therefore, that year after year, reports keep getting published about how cardiac amyloidosis mimics hypertrophic cardiomyopathy, and probably vice versa. And these are just a smattering of examples that I pulled out solely for the purposes of making the point that the two syndromes can overlap and even fool some of the best physicians. Now, making the proper diagnosis is really critical here because there are significant differences in therapeutic options and long-term prognosis between both of these entities. The slide I'm putting up over here is really not intended to show you the outcome difference between septal myectomy or medical therapy, but rather intended to point out to you that at the bottom you see I circled 12, and at the top you see I put in a line at 90% to make the point that survival with hypertrophic cardiomyopathy, even in patients that are being considered for septal myectomy, which means that they must have some outflow tract gradient, is about 90% or even more at 12 years. On the other hand, this is just a sample of an amyloid slide or an outcomes of Kaplan-Meier survival. What you see here is that 90% survival in amyloidosis, and while you could look at pre-2012 or post-2012, at least at the beginning of the 90% point, there's really not that much difference. It's about 15 to 20 months. So it's about a factor of 10 in terms of longevity of HCM as compared to amyloid, hence the importance of making the proper diagnosis. Now, my task today was to try to help you clue you in, and so I'm going to quickly, but not too quickly, go through the different clinical clues. Hypertrophic cardiomyopathy, as most of you know, is probably seen more often below 50, but that doesn't mean it isn't sometimes recognized in people over 50. Cardiac amyloidosis is usually seen in patients over 50. Males tend to predominate over females in cardiac amyloidosis. And just for background, for the most part, I'm speaking about transthyretin amyloidosis and not AL amyloidosis. The symptoms are very similar in some sense. Both groups have shortness of breath, dyspnea upon exertion. Both groups can pass out, right? Both groups have arrhythmias, although hypertrophic cardiomyopathy tends to have tachyarrhythmias and AFib, and cardiac amyloidosis tends to have bradyarrhythmias and AFib, but they can overlap even there. Chest pain is generally not seen with cardiac amyloidosis in the absence of coronary artery disease or some other confounding variable. Chest pain is more common in hypertrophic cardiomyopathy. Neuropathy and spinal stenosis and carpal tunnel syndrome are more common in amyloid. The labs probably don't help you distinguish much, except to make the point that sometimes in certain patients with amyloid, the troponins may be elevated. The EKGs do clue you in, and I'll show you some EKGs and talk about it a little bit in a moment. But briefly, an EKG in which there's LVH with high voltage is probably hypertrophic cardiomyopathy, and an EKG where there's LVH with low voltage is probably cardiac amyloidosis. Now, first-line studies tend to be echo and EKG. In amyloidosis, the echoes show granular speckling, pericardial effusions, biatrial enlargement, and thickened valves, and the EKG will show atrial fibrillation and low voltage. In hypertrophic cardiomyopathy, the echoes show systolic anterior motion of the mitral valve, increased LV mass, and high EKG voltage as compared to low EKG voltage. I don't think this is going to present all that well. I looked at it on my computer a little while ago, and I wasn't totally happy with the way it came across, but it makes the point. You can see on the left an EKG of cardiac amyloid where the limb lead voltage is low, and you can see on the right a representative EKG from hypertrophic cardiomyopathy where you see the LVH. These are echoes that I pulled out of my slide decks, and there are differences. Both hypertrophic cardiomyopathy and cardiac amyloid have thickened ventricles, and you see that there. But if you look to the left side where it's cardiac amyloid, you also see effusions and you see left atrial enlargement. You tend not to see that on the right side with the hypertrophic population. There are some indices that have been designed to try to sort this out. The summed QRS to LV mass index, right, was published back about 10, 12 years ago. It's really not that widely used, right, because there's quite a bit of overlap, and I guess I can highlight it with my pointer here in the middle here, right? And so most of us don't actually use this, but you get the point that what they're trying to say is that high QRS score tends to go with hypertrophic cardiomyopathy, and high mass tends to go with amyloid and a low QRS score. Sometimes you can distinguish the entities by looking at the right ventricle. Thickening in hypertrophic cardiomyopathy usually involves the left ventricle, and less commonly the right ventricle. More importantly, it's usually apical and typically asymmetric. Thickening in cardiac amyloidosis, on the other hand, usually involves both ventricles. It is more diffuse and symmetric. This new echo index that came into play maybe about 10 years ago, global longitudinal strain, right, can also help distinguish between the two entities when you're looking at patients whose hearts are hypertrophied. Amyloidosis is typically associated with decreased global longitudinal strain, except at the apex. But I do want to make a point. Even at the apex, those numbers that you see on the slide, minus 13, minus 14, minus 14, are not normal. Normal is minus 18, minus 19, minus 20, or even more. And so while it looks like the apex is preserved in amyloidosis, it's not preserved. It's just relatively preserved as compared to the rest of the ventricle. On the other hand, hypertension, which is depicted on the left, you can see the numbers being minus 22, minus 21, minus 18. That is even more than normal, right? And on the right, you can see hypertrophic cardiomyopathy. And while it may not be completely normal, the pattern is entirely different than the pattern that you see with cardiac amyloidosis, right? And so this slide simply brings that point home, which is global longitudinal strain is not normal in HCM, but the patterns are different. GLS alone may not be a great marker, right? It's certainly a clue, right? And it was proposed not too long ago that if you take the ejection fraction and divide it by the global longitudinal strain, you'll get something called EFSR, ejection fraction to strain ratio. And if the EFSR is greater than 4.1, it's a 90% sensitivity and a 92% specificity that the patient will have cardiac amyloidosis. So it turns out that EFSR actually outperforms strain, and it outperforms other measures of wall thickness, chamber geometry, and diastolic function. And I left you with a question at the end It's unknown if EFSR is associated with adverse clinical outcomes or if treatments will alter that. I think time will tell as this marker gets used more frequently. I kind of put the word here complementary to echo and EKG, but as I was looking at the slide this afternoon, I thought to myself that cardiac MRI isn't really complementary because it can stand on its own, even without echo or EKG. And the reason for that is that cardiac MRI does a wonderful job at distinguishing between HCM and cardiac amyloid hypertrophic phenotypes. It also defines areas of scar and infiltrate. And depending upon how much scar and infiltrate you have, it can help predict prognosis. The non-conscious MRIs may look alike, and you may say, well, they don't really look alike. The HCM MRI is convex and the amyloid MRI is concave, and there's some truth to that, but they can look alike. But the important point is not what the non-conscious MRIs look like, but rather what happens when you give them gadolinium. And the late gadolinium enhancement pattern of amyloid generally shows global subendocardial involvement. Let's see if I can point that out here, all along here, okay, the white, involving both sides of the ventricular septum. And in this paper, they called it a zebra sign. I threw this slide in just for educational purposes. It turns out that the abnormalities in global longitudinal strain correlate with the late gadolinium enhancement seen on the MRI. So you can see over here, they said that the LGE burden suggests that the regional strain gradient may be partially explained by the burden of amyloid deposition and fibrosis. So just keep that in mind in terms of the etiology of the strain abnormality. I would be remiss if I didn't come and talk about technetium scanning. Technetium DPD in Europe and technetium PYP in the United States has really come into its own as a modality to distinguish between patients who have AL amyloid and patients who have TTR amyloid, although it's not 100%, but it is becoming one of the screening studies that people send patients for when they want to look to see if there are potential markers for cardiac amyloidosis. I use it frequently, but in and of itself, it's not always enough to make the diagnosis. So I only had 10 minutes. I wanted to summarize at this point and tell you that both hypertrophic cardiomyopathy and amyloid can cause shortness of breath, dyspnea upon exertion, and AFib. Hypertrophic cardiomyopathy predominantly involves the left ventricle, and cardiac amyloidosis involves both ventricles. Hypertrophic cardiomyopathy is associated with increased voltage on the ECG, while cardiac amyloidosis is associated with low voltage. Hypertrophic cardiomyopathy is associated with SAM and apical thickening on echo, while amyloid is associated with speckling, thickened valves, and effusions. I don't think that you could ignore cardiac MRI. That's why I underline the point. Cardiac MRI is very useful. I didn't mention Fabry disease, but it is another hypertrophic cardiomyopathy mimic. Right? I did not speak about the role of genetic testing in all three syndromes, but you should keep in mind that genetic testing does play a role and it will help you sort this out. And finally, I did not talk about cardiac biopsy except when I showed you some slides at the beginning, but those were probably not cardiac biopsy slides, to make the point that cardiac biopsy can confirm amyloidosis and can confirm Fabry disease. And perhaps if you see enough fiber disarray, might even be able to clue you in for hypertrophic cardiomyopathy. So with that, I'm going to hand it back to Lisa so she can move along. But I got to stop the screen sharing.
You got to stop. Shoot, I can get that one too.
I did that.
You did it.
I did it.
Very, very, very well done there, Mark. Thank you so much.
Thank you.
Anybody who has questions, you can populate the Q&A tab at the bottom of your Zoom browser, and we'll be happy to address any questions. We're going to move along to Ethan Rowan, and at the conclusion of our talk, we can handle all of your questions as well. Okay, Ethan, screen share is up to you, and we'll get started. We're trying to be efficient tonight. We know everybody has things to do, and we want to give you information and time.
Perfect.
Thanks, Ethan.
Thanks, Lisa. So I'm going to talk about recent project that we did really in patients with known diagnosis of HCM or presumed diagnosis of HCM. How well are we doing at identifying cardiac amyloidosis? And is there anything to learn from this? As Dr. Zucker just mentioned, both cardiac amyloid, and we're going to be focusing for my talk mainly on ATTR cardiac amyloid, and HCM can result in increased wall thickening, and therefore can be overlap, and ATTR can mimic at HCM. Both of these diseases can cause left ventricular hypertrophy, and once an unexplained LV hypertrophy is identified, often a presumed diagnosis of HCM is made without significant considerations of ATTR. And that's really because HCM is common, and historically, most clinicians really think of HCM as the first thing is the etiology. That being said, differentiation between these two diseases is really critical. Treatment strategies and prognosis is different. As Dr. Zucker said, ATTR is really progressive disease. Dr. Maurer is going to be talking about novel treatment to prevent disease progression and outcomes and improve outcomes. HCM, not a specific disease treatment. For most patients, normal longevity. And then we're focusing treatment really to improve quality of life, outcomes, and older patients in particular are at particularly low risk for disease progression. There have been a few studies looking at prevalence of cardiac amyloid in patients initially diagnosed with HCM. In a study out of Mayo looking at myectomy tissue and studying the tissues histologically, about 1% of patients who had myectomy had cardiac amyloid, and about half with ATTR and half with AL. In another study out of Italy looking at clinical suspicion for ATTR or amyloid, and then also utilizing gene testing in all patients, they identified about 8% of patients who had ATTR and 1% with AL amyloidosis. But in many ways, that cohort was more of patients with unexplained LV hypertrophy and not really about patients who had a presumed diagnosis of HCM. And then when you do just gene testing in patients with presumed HCM, looking for TTR gene mutations and the diagnosis of hereditary ATTR cardiac amyloid, prevalence is about 0.5 to 1%. But each of these is very select. One is really unexplained LVH, not necessarily HCM. One is myectomy tissue, so just obstructive patients who have severe symptoms. And then the last is gene testing, which really only finds hereditary ATTR and not wild type ATTR. And so the true prevalence of ATTR cardiac amyloid in patients initially diagnosed with HCM remains unknown. That being said, in 2023, bone scintigraphy now allows for a very reliable, non-invasive diagnosis of ATTR cardiac amyloid. And using that modality, we sought to really define the prevalence of ATTR cardiac amyloid in older patients with presumed HCM diagnosis, and we performed this in consecutive patients over the age of 60 with previous HCM diagnosis. We did this in 150 consecutive patients in that age group. Each patient underwent a pyrophosphate scan to evaluate for ATTR. And then we included them in a study registry looking at pyrophosphate test results, clinical characteristics, echo, both rest and stress, echo, cardiac MRI. It was done in the vast majority of patients. We also look for extra cardiac manifestations of cardiac amyloid that Dr. Zucker mentioned, and then also study treatment and outcomes. And most importantly, we found that the prevalence of ATTR in patients with a presumed HCM diagnosis was about 3%. So 5 out of the 150 patients in our study were identified by pyrophosphate testing to have cardiac amyloid. Each of them underwent gene testing. Gene testing was negative, and thereby identified having wild type ATTR cardiac amyloid at age 64 to 73 was the age of those range of those 5 patients. And importantly, they were diagnosed with HCM on average of about 3 years before they had the pyrophosphate test. So misdiagnosed with HCM for about 3 years before the diagnosis was ultimately made. And when we looked at those in subgroups, right? So in general, we subgroup HCM into obstructive and non-obstructive HCM, and this is at rest or with provocation. Patients who had obstruction, we found no cases of ATTR amyloid, and each of the case of ATTR amyloid were in patients with a presumed diagnosis of non-obstructive HCM, and therefore prevalence is in our cohort, 5 out of 63 in patients with a presumed diagnosis of non-obstructive HCM, or about 8%. And that really highlights that while ATTR cardiac amyloid can have outflow obstruction, it's much less common to have obstruction in ATTR as opposed to HCM. But again, the myectomy cohort I spoke about earlier had about 1%. So that number is probably definitely not 0. It's probably about 1. But in non-obstructive HCM is probably in the 5 to 10% range, again, with our small number of patients in this study. Notably, the reason that HCM diagnosis was made is in large part because typical findings of cardiac amyloid were not uniformly present. In many patients, they were absent. So if you look at GLS patterns where relative apical sparing, none of the 5 had that feature. Only 1 of 5 had low voltage patterns on ECG. 3 out of 5 had asymmetric hypertrophy, while 2 out of 5 had concentric hypertrophy, more typical for ATTR. And 1 out of 3 who had CMRs had a typical amyloid pattern. That study was read outside at an outside institution as a poor quality study, but in retrospect, that was really, failure to null. The more of the failure to null, and they didn't have the special phase sensitive inversion recovery imaging. But 2 out of 3 did not have hyper enhancement on their CMR. Notably, bilateral carpal tunnel syndrome, which is really common in ATTR cardiac amyloid, was present in 4 out of the 5. So in retrospect, that is something that should have raised a flag for ATTR cardiac amyloid. When you compared the 145 patients with HCM and the 5 ATTR cardiac amyloid patients, though there was really no difference in most clinically relevant imaging or demographic variables besides the bilateral carpal tunnel syndrome. And that being said, once the diagnosis was made, I'm certainly not an ATTR cardiac amyloid expert. We set them to Rick Ruberg out of the BU Amyloid Center. He confirmed diagnosis in each of them, and each of them was started on therapy after he confirmed diagnosis. So by utilizing pyrophosphate scans, I think this is really the first to demonstrate a portrayal of the potential true prevalence of ATTR cardiac amyloid in patients with a presumed HCM diagnosis. It's really an important subset of elderly patients with HCM because they're misdiagnosed. And this is highest in our cohort in patients with presumed non-obstructive HCM diagnosed at an older age. And notably, traditional features of cardiac amyloid were largely absent in these patients, which was what really led most likely to their misdiagnosis. So I think in that setting, given the high prevalence of ATTR and non-obstructive HCM, it raises the question, should pyrophosphate testing become part of the routine evaluation of all elderly non-obstructive HCM patients? And I would say that our data at this time really can't support that. It's only 150 patients. We definitely need larger multi-center studies to look for that. But that being said, I think it really raises the need to have a very low threshold for pyrophosphate testing, particularly in male non-obstructive HCM patients diagnosed over the age of 60, to hopefully provide your patients an accurate diagnosis. Thanks.
Thank you,
Lisa?
Ethan. We have a question.
Yeah, Lisa, I was going to ask you, can I answer that?
Yeah, go right ahead.
So the question was, can we please define ATTR? So the A stands for amyloid, right? And in most cases, there are probably, well, there are, I shouldn't say probably, there are dozens and dozens, if not hundreds probably at this point, of proteins that can fold into an amyloid type pattern. So AL would stand for amyloid light chain. GEL would stand for amyloid related to gelselin. And ATTR means amyloid related to transthyretin, right? And transthyretin receptor or whatever. Transthyretin is a protein made in the liver that carries vitamin A and thyroid hormone around the body that destabilizes and becomes an amyloid fibril. So ATTR amyloid is the amyloid that we were all taught in medical school, which we used to call senile cardiac amyloid. And now we call it ATTR amyloid or transthyretin amyloid. Can I ask a question to Ethan, though? I just want to follow up a second. Ethan, I had made the observation that hypertrophic cardiomyopathy is seen more in the younger people and cardiac amyloid is seen more in the older people. But you did a study of 150 patients over the age of 60 who were referred for hypertrophic cardiomyopathy. Were these patients newly diagnosed, or what percentage of your practice shows up with not even knowing that they have HCM and they walk in the door at 61, 63, 68 with HCM?
So these were newly referred at the age of over 60 to our clinic. In general, though, our patient cohort, about 30% of patients are over the age of 60 in our HCM center.
But they weren't diagnosed at over the age of 60.
Sorry,
Right?
new diagnosis, 30%.
So 30% are diagnosed beyond the age of 60.
Yeah.
It's very interesting. And the second thing I wanted to make a comment was the bilateral carpal tunnel is what clued everybody in more than just isolated hand dominant carpal tunnel, because it's estimated that somewhere between 5 and 10% of the population over the age of 50 will have carpal tunnel or some symptoms of carpal tunnel, right? But usually they have it in the dominant hand. It's the bilateral nature of it, or the bilateral nature of it without a precipitating factor. You didn't spend their career typing or doing something that might create the problem that clues one in about cardiac amyloid.
I have a follow-up question for all of the faculty. Is my memory confused, or Fabry's and amyloidosis both have the feature of bilateral carpal tunnel?
I don't know that Fabry's has that feature. Fabry's does have a characteristic pattern on the echo in the septum. It's called a binary septum, where the endocardium tends to be a little thicker and the deposits of the alpha-galactosidase make the middle part, or the subendocardial septum, not so thick. So you see both sides of the septum very prominently. But I don't know about the carpal tunnel.
I'm going to go look.
You may be right. I just don't know.
I can remember Franco Cecchi having a discussion with me about this many years ago in Italy.
Now we have to all look it up.
So I'm looking it up too. We'll be looking at that. While we're looking at that, we're going to hand it over to Matt, who's joined us. Thanks, Matt. Welcome. So we're going to hand it over to you for therapies for cardiac amyloidosis, and then we'll try to have a little discussion after your talk with our full faculty. Thank you.
Great. So thanks everyone, and fantastic initial talks. And the main reason, obviously, we want to distinguish these two disorders is because there are emerging therapies that are quite effective for patients with cardiac amyloid. So I'll remind everyone, as we were talking about, that essentially almost any case you'll see with cardiac amyloid will usually either be AL or light chain amyloidosis or transthyretin, two different diseases in that the precursor protein here is the plasma cell and the light chain. The biology is quite different, their natural history and prognosis. There's a genetic cause of transthyretin amyloid, and it's quite terrible if you mistreat a patient with one form versus another. So, very important. It's not to say these are the only two causes, but 95, 98% of all the patients clinically seen have one of these two forms of cardiac amyloid. And just to highlight this a little bit further, so we heard AL or light chain amyloid is a disorder that affects people of middle age. A precursor protein is made by the plasma cell. It's a multisystemic disease in which the heart is involved in about 2/3, the kidney in 2/3, and there's also peripheral and autonomic involvement. And this is the form of amyloid that we all know about, in which especially if you have advanced stage disease, survival is pretty terrible, and it's treated with anti-plasma cell therapy. Wild type TTR, formerly called, as Dr. Zucker said, senile cardiac amyloid, affects older adult, particularly males. The precursor protein is a TTR. There's no known genetic cause, and there's a whole host of orthopedic manifestations. In fact, recent data we published with the Cleveland Clinic suggests that 83% of these patients have a concomitant orthopedic problem, so it's highly sensitive. And the outcome depends upon the stage, but currently the only treatment approved is a stabilizer. Whereas variant disease that's inherited in an autosomal dominant fashion, so you have a 50-50 chance of getting it, with more than 130 different variants in TTR, can affect people of a wide age range. There's somewhat of a male predominance, but not the same as in a wild type disease. And again, these individuals have both a cardiomyopathy and a neuropathy and a mixed phenotype, and the treatment here is both silencers and stabilizers. When you suspect someone has amyloid, you should get these 6 blood tests. You should always assess for AL amyloid because it's the more malignant and severe form of the disease. And these are blood tests that you can also get to risk stratify in stage patients. There's an AL staging system, a wild type, and if you will, both wild type and variant. Both of these staging systems for TTR amyloid rely on the NT-proBNP with a cutoff above or below 3,000. The Mayo staging system used troponin T above 0.05, and this used an EGFR above or below 45. And the stages tell you, God forbid, how advanced the disease is and unfortunately what the prognosis is of the patient. There is a consensus, as we heard, to non-invasively make a diagnosis, not of AL, but of TTR amyloidosis, and it really requires 3 simple steps. Make sure the patient doesn't have the substrate for AL amyloid. If they don't, you can order bone scintigraphy, and if the bone scintigraphy is positive, you can then do genetic testing. But if they have a monoclonal protein, you cannot rely on scintigraphy alone to make the diagnosis. And so I just point out to providers, please don't order a PYP scan without ordering an assessment for monoclonal proteins. It leads to misdiagnoses very, very frequently, and it's medical malpractice nowadays. So these are examples of reasons why PYP has gone awry. On the upper corner here is a patient's got a positive pyrophosphate scan with CT imaging. You can see there's uptake, but this patient actually has AL amyloid, and 1 in 4 AL patients will have uptake on scintigraphy. So it's not, specific for TTR to the point where you can use it without assessing for monoclonal proteins. These are data from our center of patients who were referred for PYP scanning, and there are 3 tests you want to get: a serum immunofixation, not just an SPEP, but immunofix to look for small proteins, a urine immunofixation, and a free light chain assay. And unfortunately, only 40% of the patients referred for scanning get all 3 tests. So that's a problem. Second is highlighted here. This is a patient who has a grade 2 uptake, and you can see by a CT scanning, the uptake here is in the chamber. It's acting as a blood pool agent. It's not in the myocardium. So this is a reason for a false positive scan, and we see a lot of these nowadays. And then there are weird mutations, unusual, but if you do this long enough, that cause cardiac disease but don't uptake PYP. So it's a great test, but it's not perfect like any test. These are general guidelines from the European Society of Cardiology that highlight certain things about patients. I'll just quickly note AFib is very common in this disease, and patients should be anticoagulated irrespective of their CHA2DS2-VASc score. There's no proven heart failure regimen. I'll come back to this in a minute. Aortic stenosis is quite common in that 1 in 7 patients with severe AS undergoing a TAVR has amyloid. And it turns out that when these patients have amyloid and develop AS, contrary to my original thought process, they should be treated most importantly with non-surgical or percutaneous interventions. Pacing is quite common in these individuals, and CRT is something that we often advocate for physiological reasons. And they rarely, if ever, die of a malignant ventricular arrhythmia. And so ICDs, despite having even non-sustained VT that you see, are usually not necessary. This is the phenotype that we see, right? A very small chamber with no capacitance. Atrium are bigger than the RV and LV chambers. And so this is a disorder of progressive diastolic dysfunction in which, if you were to remember pressure volume loops, the ED PVR is shifting upward. This blue line here is your end diastolic volume, and your end diastolic volume is plummeting. Your stroke volume is also plummeting because that's the difference between the ESV here and the EDV, and you can see it's going down. So if your stroke volume goes down concomitant with your EDV going down, your ejection fraction stays the same. So it's pretty preserved, but as you can see, because stroke volume is going down, so does cardiac output and so does blood pressure. And so there's a huge role in this disease for getting rid of standard heart failure therapies because these patients, as they advance, don't like them. These are data from our center, and 270 who were given beta blockers, no difference in outcomes, ACE inhibitors and ARBs, no difference in outcomes. But intriguingly, these are individuals who were on beta blockers in which someone decided, mainly us, to stop the beta blocker. And these are the people who continued the beta blocker. And you can see that there's a difference in survival with a hazard ratio of more than 50%. So if you want to kill your patient with amyloid, give them high doses of beta blocker, and that's sure to potentially do them in. I'm joking. Plasma cell therapy is, some people call it chemo. I prefer the term anti-plasma cell. There are a whole host of agents that can be utilized. The key here is to ally with a hematologist in monitoring and managing these individuals. It's not something you do alone. If you're treating patients, you should know about a drug called daratumumab or Darlex. That is the first and only approved drug by the FDA for AL amyloid, studied in a trial published about 2 years ago in the New England Journal called Andromeda, in which hematological response, that is lowering of the light chains back to normal, was 5 times greater in people who received Cytoxan, Velcade, dexamethasone, and daratumumab than the people who got standard treatment. And that translated into a difference in patients without events. This is not just mortality, but event rates were lower. And so this is the new standard of care that we give people with AL amyloid. AL is still a pretty rare disease. As Dr. Zucker was explaining, transthyretin amyloid is a disorder of a protein called TTR, transthyretin, or also known as prealbumin, same protein, made by the liver and exists as a 4-leaf-like clover or tetramer. Its job is to transport thyroid hormone and retinol or vitamin A. And in the setting of either aging or variance in the protein becomes unstable and dissociates into oligomers or monomers that form amyloid fibrils that deposit in the heart or the nerves. If you understand this biology, you can identify treatment strategies in which you stop the production of the protein with either antisense, small interfering RNA, or CRISPR. You can stabilize the protein with various drugs, mainly just for approved tafamidis or diflunisal off-label, maybe a drug called acoramidis in the future. And then there's this pie-in-the-sky idea you can use anti-amyloid therapies or anti-fibrillar therapies to scrub out or detergent out. None of these have been proven to be effective. They're in various phases of trials. So currently, across the spectrum of wild type and variant disease, whether you have a cardiomyopathy or neuropathy, tafamidis is approved, though most of us who take care of variant patients who have a polyneuropathy with a cardiomyopathy or without, we tend to favor the silencer-based treatments because we believe they're more effective than tafamidis. And these drugs will likely be approved, my bet is, for the cardiomyopathy patients alone shortly. Tafamidis is a small molecule that was studied in the ATTR ACT trial that fits in between the dimer-dimer interface here and basically prevents the protein from falling apart. And over this short-term trial in a small number of patients, it had a very effective 33% reduction in all-cause mortality with a number needed to treat of about 7.5 patients to prevent a death over 30 months, and an NNT of 4 to prevent one hospitalization over a year's time. Unfortunately, costs a lot of money, but highly effective, very well tolerated medication. It also slowed the decline in the 6-minute hall walk. Didn't make people better, but slowed the decline, and also slowed the decline in the KCCQ, or quality of life, over time in these individuals. The success of tafamidis has led to a plethora of trials. There's acoramidis, a super tafamidis, that's being studied in ATTRibute-CM. The first part of the study, which was a 6-minute hall walk at a year, did not meet its primary endpoint, but we hold hope for the Part B, or hard endpoints, which are going to be reported out later this year. There's patisiran, a small interfering RNA administered IV every 3 weeks. It was studied in the Apollo B trial, and I reported out the data earlier last year, but it met its primary and key secondary endpoints that were 6-minute hall walk and KCCQ. I'll show you those data. And then there are 2 subcutaneous silencers, much easier to administer because they're given once every 3 or once every month, and they're being studied in very large amyloid trials with outcomes expected at these time periods. And the outcomes here are hard endpoints, mortality and CV hospitalizations. The theory behind interfering RNA, antisense, or CRISPR is shown here. You're making a bad protein, it becomes unstable, it gets stuck in your heart and causes the phenotype. And by blocking the production, you can reduce the unstable circulating tetramers, you can clear maybe amyloid, but prevent deposits for sure, and minimally stabilize the phenotype, which tafamidis didn't completely do, and maybe even recover the phenotype. These are the Apollo B data that we presented in 360 patients who were randomized to receive patisiran in a blinded manner every 3 weeks IV or placebo. And you can see in patients who received placebo, there was a slow and steady decline over a very short period of time at 12 months in their 6-minute hall walk. And in those who received patisiran, it was more stable with a statistically significant, we'll debate clinically significant difference over a very short period of time. And these are the same data showing the KCCQ with, again, statistically significant differences over just a 1-year time period. Quite surprisingly, over the same time period, the data from this trial showed, as you can see, that global longitudinal strain was statistically better in those receiving patisiran. LV mass was less. The heart chamber size was slightly bigger in those on patisiran versus placebo, and many of the other parameters, including cardiac output, wall thickness, and so forth, didn't meet statistical significance, but pretty impressive echocardiographic effects over a short time period. This drug is currently in front of the FDA for consideration of approval for cardiomyopathy. It's been on the market since 2018 for neuropathy. And then the latest way to silence, if you will, TTR is using the CRISPR-Cas9 system. Kind of unbelievable in vivo human data presented, published in the New England Journal, and more recently presented at the AHA as a late breaker in patients who have cardiomyopathy. And this is a lipid nanoparticle that's laden with the TTR specific guide that brings the CRISPR-Cas9 scissor. A single IV infusion goes to your liver, taken up by the hepatocyte, and permanently shuts off the production of TTR. And in patients, humans who had either class 2 or even 3 heart failure, these were the reductions in TTR that were observed. So very high knockdowns of greater than 90% in these patients. So we have great hope for this, and this will be entering clinical trials, we believe, later this year or early next year. So I'll just conclude by saying, this is an unbelievably exciting and evolving landscape. Tafamidis was studied in the polyneuropathy trial in 2011. The ATTR ACT trial began enrollment in 2013, and the results were published, and tafamidis was on the market in 2019. We learned how to leverage, as we heard, the non-biopsy PYP diagnostic approach. And you can see there's a lot of white over here in that there's a whole host of clinical trials and position statements by the AHA and the ECC that have emerged in this very exciting, clinically robust space, despite the fact that we've had to deal with a lot of challenges, including COVID. So I'm thrilled to be with my colleagues and talk further about this important distinguishing factor between HCM and amyloid heart disease.
That was fantastic, Matt, Ethan, and Mark. I think we have a good foundation now for our viewers to maybe take a different look and gather a deeper appreciation for where these two disorders can be a little bit confounding and confusing to get the diagnosis. But understanding that there are treatment pathways for these amyloid patients that are very different than the HCM patient, we want to make sure they get the opportunity to get the right treatment in time. We do have 2 questions in queue. Please feel free to publish any questions as we're going through. What is measured in the hall walk test to indicate success? Oh, that's a good question. Outcomes measurements.
Yeah, so the 6-minute hall walk is just as it's described, a time test in which patients are asked to walk up and down a hall and try to cover as much ground as possible. Cut points, so you understand, are usually measured in meters. Patients who are usually NYHA class 1 can walk more than 450 meters. Patients who are class 2 walk between 300 and 450 meters. People who are class 3 or below 300 meters, and class 4 patients usually can't ambulate very far, so usually it's quite poor, under 50 meters. Those are some references. The average in patients, for example, with amyloid is about 320 meters. There's a wide variance. And what's clinically significant, usually a change of at least 30 meters is considered clinically significant. So that's why I mentioned the Apollo B data, I think, met a statistically significant difference, but people could quibble about whether 15 meters is really, or 18 meters, which is really clinically significant. The concern in amyloid heart disease is you don't get anything back, so if you don't intervene and they lose 18 meters the first year and they lose 36 meters the next year, and so whether the FDA will agree to that will be up to them, but those are some of the reference points. Just so you have a sense, in the ATTR ACT trial, at 6 months, there was like a 50-meter difference between those who received tafamidis versus placebo. Having said all that, it was more than 10 years ago that those patients begun to be enrolled. They were much sicker, and those changes are not, thankfully, things that we usually see anymore over short periods of time because patients are healthier.
That is helpful. I'm going to slaughter the name of this drug, and I apologize in the question. In a patient with AL cardiac amyloidosis, now in remission, free light kappa chain within normal limits after a year and a half on daratumumab.
Daratumumab. Yeah,
Thank
Darlex.
you.
Yeah.
Thank you. How long should this treatment be protracted?
Yeah, no one knows. It's a great question. So what someone's describing is that the goal of the therapy has been achieved. That is, the light chains have been lowered. And when the light chains come back to normal, you've reached what we call a complete or a hematological response, or CR, as the hematologists describe it. Obviously, this is not a curable disease. So if you shut off the drug, there's the potential for the light chains to return. So some hematologists, including people at our place, will give maintenance therapy. How long is maintenance therapy being given? Some providers give it for a year or two. I've seen up to 3 years, but there's no randomized data to describe. The alternative to doing that is, since you have to often receive this therapy at least once a month if you're in maintenance phase, is to hold the therapy and then recheck your blood tests every 3 months or something. And if the light chains start to come back, then you can obviously restart the treatment. So those are some approaches, but it's an excellent question, probably by my sense is someone who has the disease and is getting the drug, but I hope that answers it.
Can I ask you 2 questions? Right, I forgot whether it was you or Ethan who pointed out the 8 or 10% in the TAVR population are found. It was you?
It's more than 8%. In our study, it was 16% overall, and 22% of men have.
And so let's follow through with that, because you mentioned that these drugs are expensive, but you didn't actually mention how expensive they are. And the patients who are going for TAVRs are 88, 90, 91. What do you do with these people? Do you commit them to multiple $100,000 medicine?
So you're completely correct that the medicines are ridiculously expensive, and I would tell you inappropriately expensive. It's
We
not
agree.
like these compounds are just to put a flavor to it, it was $225,000 when it was initially approved for a year. that's $670 per pill per day if you just break it up. By the way, the price went up by 4.4% in
39.
2022. Why did it go up 4.4%? Because companies are allowed to raise it to 4.4. If you go to 4.5, you're not allowed to do that. So the dilemma in the United States is we allow companies to charge whatever they want. Other countries don't allow them to do that. And just let you know that tafamidis is available in many countries for the cost of $40,000 or $50,000 a year, much cheaper in the United States. Back to your question, though. Yeah, I mean, there is not, unfortunately, usually a safe alternative. There's a drug called Dolabit or diflunisal, which Jeff Kelly, who invented tafamidis, modeled it after. It's a non-steroidal that's used at low dosages and probably very well tolerated, truthfully. So that could be used as an alternative. I've seen almost 1,000 patients, and in the phase 3 open label extension trial, we enrolled 148 people. And when I told one guy that the drug was not going to make him better, was going to cost him a lot of money down the road, and it was the only person I've ever encountered who refused to take the drug. So most patients do want the drug. Their out-of-pocket costs are variable. Some patients pay nothing, about a third. A third of patients pay pretty minimal amounts, like $50 a month, and then a third of patients pay several thousand before they get into the donut hole, like $3,000 the first month. And over the year's time, they're paying between $12,000 and $15,000 a year. No one pays for these drugs themselves because that would, I don't know who could afford it. But it's a very big problem, Mark. Really.
So you alluded to my second question inside of your answer when you said, I told the patient that it won't be making him better. All right. Now, you and I certainly remember the days, the 1980s, when we told the patients who were put on Mevacor that it wouldn't reduce the plaque in their coronaries, but it would at least slow the progression. And I think we now know that if you get the cholesterols low enough, probably there is regression of the plaque. And so the question I guess I'm going to ask you is, tafamidis might give you 90% stabilization. The silencers might give you 90% knockdown, right? Is there evidence that there is regression? Because you pointed out that in some of these trials, the LV chamber size began to increase.
Yeah, there's not a lot of very good evidence of regression. Whether that's because it won't happen, we don't know. Is that needing longer term studies? Remember, this is a disease, as I think Ethan pointed out, that people have had for at least 3 years before, quote unquote, the diagnosis was made. But it's a very indolent disorder. And so people have probably had this for decades, right? I mean, the carpal tunnel and the other things occurred. So I think we just need a lot more data and longer term to know. I think your framing is very important, though. It's important to be honest with a patient and tell them what to expect from this therapy, which is, to be honest, during the ATTR ACT trial, none of us thought tafamidis was working. Why? Because on average, everyone was getting worse. And we as doctors were like, we didn't know that some people were getting worse much faster than others. So it's a great, well-tolerated therapy with a brilliant biology behind it, but it certainly implies we can do a lot better for our patients.
Well, it is important to keep in mind that the deterioration in the 6-minute walk time and some of those other metrics would happen in an 85-year-old over 30 months, even if they didn't have amyloid. So that it's hard to compare.
Yeah, that just so you know, in truly healthy individuals, the change in a 6-minute hall walk over time has been well studied. It's like 7 meters. These people drop by like 100 meters. So this is outside the pale of someone who's just, now most 80-year-olds are not healthy to begin with. So I agree with you. They would all decline, but it's, and what matters most to older adults in my experience, they tell me, is staying independent and functional and being able to go see their family members and their grandkids and those kind of things. So the 6-minute hall walk is a pretty, I'd say, relevant clinical test in that regard.
So, Ethan, let's bring you into this conversation a little bit. Were you surprised by the number of amyloid patients that popped up in your large cohort? And what do you think we can do to tease them out earlier in process?
So yes, was surprised. I thought it was higher than I thought it was going to be, especially in non-obstructive. Thought it was going to kind of be equal between and low. The answer in terms of how to get them in earlier, I think, is one, having a better understanding of red flags. So in our study, as I said, it was bilateral carpal tunnel, which was relatively sensitive, though wasn't specific. 15 of the patients with HCM also had bilateral carpal tunnel syndrome. But that's a signal definitively that they need more testing, in my opinion. And then, I was giving each of those other disease markers as aggregate. But if they have even one potential flag for cardiac amyloid, again, I think that signals need for a pyrophosphate test in that patient.
So I did a little digging while Matt was talking, and I did find a paper from 2017 making the correlation of bilateral carpal tunnel syndrome to Fabry's disease as well. So maybe if we start asking for new patients, is there bilateral carpal tunnel syndrome? That might give us some ideas who need to go for genetic test or more invasive test to rule out amyloid. I think looking for some simple tasks to help pull these people out of the HCM big bucket and put them into their amyloid or Fabry's bucket, I think is probably a wise idea. And we're going to try it in the HCMA's new patient journey registry. That's going to be a new question that we're asking on intake. And we're going to see what we can find out from the community at how many people with HCM have bilateral carpal tunnel. And from there, maybe we can help them get to diagnosis faster. Oh, we have another question. I'm being a bad moderator right now. What are the pediatric implications of a positive family history? Is amyloid disease ever looked for in pediatrics, or not until the child is over 60?
Yeah, I mean, it's a great question. So obviously what you're describing, I think, is the construct of the genetic form of the disease in which family members could inherit the same gene at a 50-50 chance. In general, it's somewhat dependent upon the particular variant. So there are variants that can affect people very rarely in their 20s and 30s. The most common one is one that affects people of a Portuguese descent. It's also seen in Sweden, Japan. It's called the V30M mutation. But in general, in the United States, almost everyone who has this disease, as Ethan described, is usually over 60. So I wouldn't say you shouldn't look for it in 40 or 50 years old, but we don't recommend that 18-year-olds, for example, family members carry a particular mutation that's common in Blacks, get tested at that age, because the chance they have a phenotype is essentially zero. They may have the gene, but they're not going to have something that's attributable to that particular problem.
What about at 45?
Yeah, 45 may make quite a bit of sense. And there's a whole push to make earlier diagnosis. So we have a few NIH grants in which we're looking for the phenotype earlier using, as people pointed out, MRI and some other things. So, but a 20-year-old, I think it's not a useful thing. And genetic testing, while fantastic, because you either know if you have it or you don't, and there are some potential downsides. You could, God forbid, be denied disability, life, and long-term care insurance, and so people need to be counseled appropriately before they all of a sudden change what is a completely healthy person to someone who carries a gene that might penetrate one day or might not. But unfortunately, insurance companies will look very differently at them. So
We've learned this week that a company has gotten approval to move forward with genetic therapy in hypertrophic cardiomyopathy later this year. Do you believe that there will be a role for genetic therapies in the amyloid space?
oh yeah, there are. I mean, the therapy I mentioned, which is CRISPR, you might argue is a pretty highfalutin therapy. The idea that you can literally silence and shut off for permanently the production of a protein in this circumstance that's causative of the phenotype. And the drugs that we take right now or give do that, but to do it permanently might be in some ways fantastic for patients. One infusion, thanks for seeing me and I'll come back when I need you. At the same time, who knows if you shut off TTR, if there'll be a problem 10 years from now, then you'll be, as I like to say, up a creek, where without a paddle. So, I mean, these are really exciting emerging constructs, but I think we should all just, counsel patients cautiously. Maybe fine to live without TTR for a few years or a low level, but for 40 years, who knows? Right?
Interesting. Okay, well, I promised everybody a very efficient hour presentation, And we have topped out the hour. And I know when I said 10 minutes, guys, they went, that's really fast. But I hope we were able to impart some knowledge on everybody and get you to think and change some protocols maybe in-house to identify HCM from amyloid and potentially from Fabry's, as we kind of brought up here today too. I want to thank you all for your time and attention and your participation as faculty and members of our viewing public. This will be, this program will be sent out to our HCMA Recognized Center of Excellence partners for viewing later, and it will be available on YouTube in a couple of weeks after it's circulated internally. Please do stay tuned for international programming coming up later this year, where we will dive a little bit deeper into the same topic, but look at it from an international lens. I do again remind you that February 22nd is HCM Awareness Day. Please visit the HCMA website for information on how you can participate. And please go see the movie A Man Called Otto. It is a very, very nice look inside the life of somebody with HCM, even though he's grouchy. We're not all grouchy, just letting you know. Thank you all so much. Have a great
Thank
day.
you.
Oh, wait. We got another question. Wait, is it a? Yes, the recording will be available. It's going to be a little while. We're going to keep it internal, see what we get the views on. It'll be a private link, so you'll get a copy of it so you can share it with your colleagues. And then after about 2 months, I think we're going to open it to the public. So it will be available. Thank you all and
Bye-bye.
good night.
Thank you.